technical assistance accessed by communities and civil society partners for this particular area of work. Colleagues from the Global Fund also provided some insights into how mental health services and programs could be integrated into country Global Fund grants. So next slide. So in this final installment, in addition to showing country example of integrated mental health, HIV, and TB services, we want to also take a closer look at the resourcing issue, in particular from the perspective of domestic resource financing and other bilateral resourcing opportunities. And in this regard, we're excited and humbled to have the speakers from India, the Philippines, Vietnam, and Nepal with us today to share their work and experience. But before we start the presentations today, I would also like to first invite the two other co-organizers to introduce themselves and give few words. So first, let me invite Zulinka, the Policy and Advocacy Advisor from the United for Global Mental Health, to say hello and give a few words first.
Thanks, Jen. Hi, everyone. My name is Ives. I'm currently the Policy and Advocacy Advisor at United for Global Mental Health. We've been very grateful for this continuous partnership, not just with GFAN Asia Pacific, but also across different organizations of the 7 Alliance. So we're very grateful that you joined us up to the last installment of the 3-part webinar series. So our stand is always around integration as the way forward. So we must continue to look for sustainable opportunities in integrating mental health components into services and even the broader health system, not just for communities within the HIV and TB space, but even in other disease areas. So we must continue learning from different communities, and this is one way to actually do it. So we started with the what, and now we're moving forward with more on the how, and hopefully we can further forward those conversations into actions on the ground within our own respective countries. So thank you for this opportunity, and back to you, Jen.
Thank you, Ive, and you'll hear a little bit more from Ive later on as well. Next, let me invite Bikash Garun, the Regional Coordinator for Network of Asia Pacific People Who Use Drugs, NAPU, to give a few words on behalf of the 7 Alliance. Bikash?
Okay, thank you, Jen. Hello, everybody. My name is Bikas Gurung, and I'm the regional coordinator of NAPUD. NAPUD is the regional network of people who use drugs, and we are part of the 7 Alliance Consortium. I think on your screen you can have a look at which other organizations are there. So yeah, thank you for having me here, and it's a privilege to be here, of course. And since this is a very important topic about the webinar about the mental health, of course, we are all working with different communities from HIV, TB, malaria, and specifically those diseases. I don't have to actually emphasize the importance of integrative mental health services for our communities. I think, so yeah, just to quickly say that the level of awareness and the need for urgent need for mental health interventions for our communities is there. So I hope that we will have a very fruitful and productive discussion, and this webinar will also have some outcome around how we are going to deal with the advocacy issues around mental health. So yeah, thank you, Jen, and thank you, everyone. Have a great webinar. Wishes to all the speakers as well.
Thank you so much, Bikash. So before I introduce our first speaker, please note that we'll take questions and comments to the presentations at the end of all the presentations after all the speakers have presented. And I will help us facilitate the Q&A later on. And in the meantime, please feel free to drop your comments and questions in the chat box throughout the session. And a kind request to all the presenters to please have a look at the chat at the end of your presentation in case there are questions addressed to you. And feel free to respond directly in the chat as well as responding during the Q&A session later. And now, without further ado, let me introduce our first speaker, Ms. Prabha Mahesh. Prabha, are you here?
Yeah, I'm unable to see my video. Can't remember.
Oh, no, and we're not able to see you.
My video is on,
Oh, we don't see you. We hear you.
or I can't. Can you hear me?
Oh, we hear you. I hear you. I'm assuming everyone else hear you. Okay.
Yes, we can hear.
Can you see the screen?
Yeah, I can see the screen.
Okay, then shall we proceed? I'm really sorry we're not able to see you, and maybe we
Yeah,
can.
I can see my screen. Yeah.
Okay, great.
Yeah.
Okay, good. So let me properly introduce you to the group before I turn the floor over to you. Prabha Mahesh is a public health professional with a deep commitment to ending TB. She holds qualification in psychology, social work, psychoanalysis, and healthcare management. She is currently the director of health projects at Alert India, where she designs, implements innovative programs to address TB, HIV, and community health. And we're very glad that she's able to join us today to share about resourcing opportunities and challenges of integrating mental health services in India's TB program. And some of you might be aware that India is one of the high TB burden countries in our region, and also in terms of the global TB burden landscape as well. So we're very, very pleased that Prabha is able to join us, and let me turn the floor over to you, Prabha.
Good afternoon, everybody. Thank you so much, Jennifer, for presenting this opportunity. And I'm very proud to talk about TB and mental health today. Having lived experience of TB, probably what I suffered most was the mental agony than the disease itself. So it gives me immense pride to present this subject in front of all of you. So TB and mental health. Next slide, please. So as we discussed, India continues to bear a significant burden of tuberculosis globally. And we have more than 1/3 of the world population who are affected by TB. So the highest TB burden globally, India has the highest TB burden. And significant decline, though we've been working in, our efforts have been working towards reducing the mortality rates. But still, annually, we have approximately 2.6 million new TB cases, and we have TB deaths as well. We have around 400,000 people dying from TB in India each year. So the next slide. Mental health at a glance in India. The prevalence of mental illness, 10 to 20%. This is the data. Of course, I do not have the exact details of the specific disorder, but 10 to 20% of the population do have, there is mental illness prevalent in them. And almost 50 million Indians suffer from depression. 38 million Indians suffer from anxiety disorders. And 1 in 4 suicides that happen globally. That's the rate, suicide rate in India. And as far as mental health infrastructure is concerned, sadly, we have a deficit over 1 million mental health workers, professionals not available to serve the patients. And mental health expenditure, it was initially less than 1%. Now it is coming very close to 1% of the total healthcare budget is allocated for mental health. So the perception of TB, as all of you know, that TB is more seen on a clinical perspective. There should be a paradigm shift to move to the psychosocial perspective. TB and mental health are closely intertwined. They have a bidirectional relationship. And more so, all of us are aware of the stigma, depression, anxiety, and even suicidal thoughts, and including the side effects of medicines. So conversely, mental health conditions can increase the risk of contracting TB and hinder its treatment. Next. So we say that TB and mental health is an interplay of dual factors, like TB impacting mental health and mental health impacting TB. So we see there is a direct impact. It even begins even before the diagnosis. When a patient is asked to, so symptomatic is asked to get tested for TB, the stigma starts right from that period. And so that's where the anxiety starts. And there is a direct impact that the TB has on mental health, and the pain and discomfort experienced during the disease, and it also restricts the cognitive functions. And the treatment duration itself is a kind of mental agony for the TB patients. And of course, the indirect impact being the social stigma discrimination that leads to isolation and low self-esteem. Financial burden can also cause stress and anxiety, and there is a fear of the side effects of treatment. Similarly, when we see the mental health impact on TB because of depression and anxiety, there is generally some kind of a delay, or there is an intermission in the adherence, leading to poor adherence. And also, chronic stress and anxiety may weaken the immune system, and they may be susceptible to infection, and also health-seeking behavior. So mental health issues can cause delay. As I said, when a person knows that probably he's suffering from symptoms like TB, they do not want to get tested because of the stigma. And of course, the effectiveness of the treatment also gets compromised. Next. So what I have seen in India, having served the patients, so there are typical symptoms that we see on both male and female. And generally, many of them are common. But what is very eminent in men is that there's always a strong sense of insecurity, financial insecurity. So there is an anxiety about losing the job, loss of employment, and of course, isolation, and also alcoholism. And there is it affects their self-dignity also, and they are unable to face the stigma. So that is very, very common in the male patients. But what we see in the women is it's more of anxiety in terms of guilt, induced guilt, the fear of spreading the disease to the family members and the close connects. There is also a stigma and an emotional insecurity. And in a country like India, what's very eminent is the insecurity in marriage, because very, very often there are broken families, they are thrown out of marriage, or there is a constant fear that in terms of intimacy, that their intimacy is getting hijacked because they being in isolation. So these are the typical mental health issues that the women actually go through. And of course, the side effects that shows on the skin and the face, there is a lot of physical consciousness in women, and of course, financial insecurity. Next. So what are the challenges like? As we know, first, the most important challenge here is the lack of awareness. There is stigma, but people are not aware, like scientifically, what is happening. TB is curable. Sadly, knowing that it is curable, but still the stigma is very much prevalent in the families, maybe workplaces, and even in the community, because they do not know about the disease. And that is the biggest challenge. And most importantly, inadequate mental health infrastructure. As I said in the earlier slide also, there is no proper, first of all, it is underfunded. There are no proper adequate funds available for mental health. And also, even if a few services are available, it's not an effective service delivery system. And we need to compromise the quality. It is an inadequate quality of care. And again, the healthcare system is fragmented. There is no coordination between TB and mental health services. In terms of even psychologists or the therapeutic intervention, psychiatrists being available, there is absolutely nothing, no proper multidisciplinary system that is already available at the health level. I mean, the infrastructure itself is very challenging as far as health is concerned. And poverty and added economic disparities, of course, all of us know that poverty and that adds to TB and mental health problems, and that limits the access to healthcare and social support. So even if they, first of all, they're not even aware that there is any psychosocial support available. Even if there are therapy sessions, even if there are facilities available, they cannot afford. Probably they are too poor to even afford luxury like going for a therapy session. So poverty and economic factors and educational disparities, of course, as we said, They're not even aware that there is something called a behavior science, and there are specialists and experts, and they need to be, they have to consult these experts probably to get relief from any mental health disorders. So they're not even aware of that. And drug resistance, of course, drug resistance TB is again, it is a huge time bomb as far as Mumbai is concerned. That's the business capital city, business capital of India. And definitely there is a lot of devastating impact in terms of mental health. And of course, the adverse effects of the TB treatment. And there is peripheral neuropathy, depression, that can worsen the mental health conditions. And of course, the most important challenge here that we see is the community mobilization to break barriers. There is a poor social response. So even if there are influences in the community, it takes a lot of efforts. Actually, it happens. I'm not saying it doesn't happen, but it's a Herculean task, and a lot has to go. A lot of advocacy from the country is required for that. It's a big time game. Next. So strategies to address the dual burden of TB and mental health. Early interventions, especially, as I said, right from screening itself, or I would say even a pre-test counseling for tuberculosis is very important, and a psychological support. Unfortunately, communication is confused. Patient communication is confused with counseling. So there has to be a proper counseling. We support group interventions. They should be able to help them cope with the challenges of TB and the treatment. And there should be medication management in terms of ensuring adherence to TB medication. And there should be a proper treatment literacy in terms of how to manage the potential side effects of the disease, of the treatment. And stigma reduction, a lot of work has to go in terms of reducing the stigma. In case if a TB patient has to improve mental well-being and have better treatment outcomes, a lot of effort has to go in here. Multidisciplinary team, as I said, there has to be a psychological assessment done even to understand, even at the beginning of the treatment, it's important. A clinical psychological assessment has to be done. Maybe the patient is already suffering some kind of a mental disorder, and the patient is going to be taking treatment. So it is very important to understand the psychological climate of the person before even we start the counseling process. Capacity building of healthcare workers for strong psychological intervention. There is a lot of requirement in terms of strengthening. There need to be a capacity building for the healthcare workers. And integrate mental health is in the TB care cascade. It has to be an integral part of the entire disease control program. I think mental health has to be the nucleus for all disease control programs that has to be integrated within the health system. Next. So the big problem here is funding for the mental health program and TB. So what is available in India? So we have something, the National Mental Health Program. It provides financial support for various mental health services, including rehabilitation, skill enhancement, community living for people recovering from mental illness. So if the program actually allocates 6 lakhs per center per year for rehab. And we do not know how much they actually receive, but that is the allocation. And the medical colleges and hospitals with the psychiatric departments, they should be receiving at least 50 lakhs per year for mental health services. Unfortunately, we do not know what is the reach like, but the allocation for the latest 23-24, it was like 919 crore, which means 1.03 of the total health budget. And the last year, the 24-25, we have had almost 1,000 crore, which is 1% of the total health budget. As far as TB is concerned, we are under the National TB Elimination Program. The diagnosis, treatment, and the adherence is all free and being followed by the NGOs and the government for the both private and the public sector. And each patient receives 1,000 rupees as a incentive, which is for the nutrition, which is called the Nikshay Poshan Yojana. And there is a person who's supporting the patient, that is called the Nikshay Mitra, the friend of a TB patient, who also receives an incentive. And the country has tuned in 54,000 contributions. There are for 54,000 people who are aiding these TB patients. So that is the funding part of, but there is no common fund for TB and mental health put together. These two are totally watertight compartments flowing in from each other. But we have still need to work a lot on how do you gain the synergy of bringing, we need to still converge these two services and ensure that the funding is also being utilized by both the units. Next.
Great. Papa,
So-
can I pause here with your presentation because I'm sorry, just in terms of the time, but I thought that might be a good place
Okay.
to
Yeah.
pause. And then because the next presentation, I'd like to, and thank you for that, because I think your note on how we could optimize different resources within the government health budget will be a good transition for us to the next presentation from Roy at the case of the Philippines. So, and we will make the rest of the presentation available online later after the sessions for other participants if they want to take a deeper look. Yeah.
Sure.
Great, thank you so much. So, thank you again for that really insightful look into the situation of India's TB program and the challenges around integrating mental health services, Prabha. Let me then move on to Roy Dahi, who's the co-founder of Mental Health PH, an organization in the Philippines dedicated to promoting mental health awareness and providing resource and support for mental health well-beings. The organization aims to create a safe space for people to discuss mental health issues, break stigma associated with mental health condition, and connect individual with the help they need. And we've invited Roy to share the CSO perspective in the Philippines, given that the policy development achieved in the Philippines, such as the Mental Health Act and the Universal Health Coverage, PhilHealth, touching on the PhilHealth coverage for mental health condition, and see how mental health services could be integrated into the National Health Insurance Scheme. So again, really looking forward, really looking at the opportunities and challenges of mobilizing domestic resource to support and increase access to quality mental health services. So Roy, the floor is yours.
Thank you so much, Jen, and good morning, good afternoon, and good evening, everyone. Thank you so much for inviting me here. It's really an honor to be one of the speakers for this very prestigious webinar. I'm Roy Dahil from #MentalHealthPH and a mental health advocate from the Philippines. I'd like to start my session by re-echoing what Dr. Tedros from the World Health Organization said, that mental health must be an integral part of universal health care. Next slide, please. The Philippines made significant strides in institutionalizing this through a policy when we passed the first mental health law in 2018 and the Universal Health Care Law in 2019. Next slide, please. Just to paint a picture what a typical Filipino mental health service user look like in the Philippines, let me introduce to you our co-founder, Lawrence. I met Lawrence in 2016 when I started #MentalHealthPH, and back then we did not have mental health law, and conversations on mental health and mental illnesses remain a taboo. Lawrence was diagnosed with bipolar 2 disorder and generalized anxiety disorder. Apart from regular therapy sessions and follow-up consultations with a psychiatrist, she takes 2 to 3 medications daily to manage her symptoms. A pill would cost roughly $1, so that's around $2 to $3 a day, on top of a bi-monthly therapy session that range around $30 to $40 per visit. The average income of Filipinos in the Philippines is around $230 a month. Lawrence spends roughly $180 for mental health services alone. And these are out-of-pocket expenditures since the government insurance program does not cover outpatient mental health services. Lawrence is just one of the many Filipinos who struggle to receive care for their mental health due to high cost of service. And in most scenarios, mental health is just one of the health problems Filipinos are facing. We struggle with cardiovascular diseases, cancer, diabetes, tuberculosis, and sometimes a combination of this. And since mental health conditions mostly have no physical manifestations, they are being placed on the back burner by most Filipinos. Further widening the gap, health issues like mental health, HIV, and TB are highly stigmatizing, and oftentimes people would opt to hide rather than seek professional care. Next slide, please. During the Mental Health Day celebration in October last year, with mental health law and universal healthcare law as a legal basis, our national government insurance program expanded its coverage to include general and specialized mental health service. That means every Filipino will automatically be enrolled to our insurance program, which can cover $150 to $280 per person per year to cover essential diagnostic services, assessment, and follow-up consultations from accredited facilities on top of free medications for mental health. This insurance also covers mental health conditions. This insurance only covers mental health conditions related to depression, psychosis, epilepsy, child, adolescent, mental health, and behavioral disorders, dementia, and self-harm related problems. Although these are significant strides to achieve universal health care, especially improving mental health services, but on civil society organization standpoint, we continue to advocate for more as these are not enough. The progress on this front can be summarized in three words. It's slow, and it's siloed. Next slide. First of all, it's very slow. Mental health law was passed in 2018, universal healthcare law was passed in 2019, and the PhilHealth outpatient package for mental health services was only launched 5 years later, just last year. And even up to now, only less than 10 facilities all over the Philippines are accredited to offer these free services. So it took them 5 years to develop this package. And even if it's already been launched, we still do not have enough facilities to be able to cater this. Second, next slide, it's low. Allocating $150 per year to cover professional fees, diagnostic examinations related to mental health, and assessments is not enough to cover the majority of the expenses needed for quality mental health care. We need more in order for a service user in the Philippines to be able to give quality mental health care that they need. Then finally, next slide, it's siloed. It's siloed. Borrowing this line from one of our lawmakers, we may give every Filipino's insurance package, but it is useless if there are no facilities that they can present and use this package for treatment. Like in the Philippines, we only have 10 for all over the country. We may build more hospitals and clinics, but it will be useless if there are no doctors, mental health professionals, trained mental health professionals for HIV and TB, healthcare workers who will run these facilities and clinics. We may have cadres of health professionals, but the road to wellness will be blocked if the medicines are also expensive. We may improve the services of health facilities, but when the sick are continuously dumped on them because we did not pay more attention to the promotive and preventive aspects of health, then we have failed to address the roots. Mental health challenges are intersectional. We need to make sure mental health services are always included as it affects and transcend across other public health problems like in HIV, like in tuberculosis infections, in cancer, and among others. Health challenges are interrelated. They're linked together in one big system, and so the intervention must not be compartmentalized but comprehensive. Next slide. Let me close this with a frequently used Filipino phrase for mental health advocates in the Philippines. Malayo na pero sobrang layo pa rin, which translates to, we have come a long way, but it's still a long way to go. We have to keep fighting for comprehensive and quality mental health care for everyone. And like we always say in Mental PH, together we can achieve a mentally healthy community. Maraming salamat po at thank you so much.
Thank you so much, Roy, for that really comprehensive, but also really sobering picture of the situation in the Philippines. I think Philippine PhilHealth has always gotten a lot of attention in the space of UHC, and it's really sobering that progress has been slow. But I think from both yours and the case from India, from Prabha. I think what we are getting out of it, it's integration is one of the key messages coming out from both the example. And while we continue to push for adequate domestic resource for quality mental health services, I think we also want to find ways, and it's important for us to also continue to advocate to donors and funders about this need as well. And as such, it is with great pleasure that we have colleagues from USAID PEPFAR EPIC project from FHI 360. They're able to join us today and share their experience and perspective. Before we move into the country presentations, then let me first invite Steve Mills, the Asia Regional Director for USAID EPIC project at FHI Regional Office, to help us set the scene. And Steve, while you getting ready, just a little bit about Steve. Steve, again, is a regional director for the USAID EPIC project at FHI, and in his capacity, he manages intervention and approaches that try to optimize HIV prevention, care, and treatment cascade for key populations. Especially community-based approaches that reduce stigma and discrimination. And he's also very much involved in sustainability of these approaches through promoting social contracting and universal health care reimbursement schemes. So Steve, I understand that there will be 2 country presentations as well from your end, but I will turn the floor over to you to help us set a scene and introduce our colleagues from Vietnam and Nepal. Steve?
Great, thank you so much, Jen, and a big thanks to the organizers of this for including the USAID EPIC project and FHI 360. So you're just going to hear from me very briefly before I turn it over to representatives from our 2 country programs, first of all in Vietnam and then in Nepal. Some of the audience on this call may be familiar with the USAID EPIC project. It is a global HIV project supported by USAID. It's now in its 5th year of operation. In Asia, it is in operation in 13 different countries, so you'll be hearing from 2 of them. And the main goal of EPIC is to support the introduction and scale up of HIV cascade interventions. So very briefly, HIV testing, prevention in terms of PrEP, and then antiretroviral treatment. The focus of most of these country programs in Asia are with key populations, whereas an EPIC in Africa is focused not only with key populations, but general populations and young girls and adolescent women. Before COVID, these interventions were much more narrowly defined than they are now. And I think with the advent of COVID, this brought the issue of mental health to the forefront, because I think, as everyone on this call knows, that COVID really highlighted first of all, the need and the gaps in mental health services, just because of people having to be located at home and not have the typical social support networks that they have. And so there was a lot of advocacy from the community partners that we support to USAID to start to incorporate more mental health interventions. And this was fortunately very actively received. And so now, over the past 3 to 4 years, there's been active growth of more mental health related services for key populations, with those key populations including men who have sex with men, transgender populations, people who inject drugs, and sex workers. So with that, I want to turn it over to first our Vietnam representatives. But both countries, both Vietnam and Nepal, will be talking to you about how these mental health interventions have been integrated into HIV services and actually helped these HIV services to be scaled up. So the first person you'll hear from today is Vuong Anh Tu, who is Associate Director for Health System Strengthening with the EPIC project with FHI 360 in Vietnam. And then after a few slides, she'll be turning it over to Chan Thi Thanh Quy, who is Project Specialist for COVID. But still, even though COVID has now declined significantly in Vietnam and other places, a lot of that mental health work is still continuing. So Huy is very much involved in that. So Tu, I'll turn it over to you, and then you can pass it to Huy when you're ready, and then we'll move to Nepal after that. So Tu, please.
Thank you, Steve. Hi, everyone. I am Tu. It's such an honor for us to be here to present you our work on mental health. Next slide, please. As we all know, mental health challenges significantly impact people living with HIV and those at risk of HIV. So these challenges can hinder treatment adherence, health outcomes, and well-being. That is why integration matters. Integrating mental health services into HIV program is essential for achieving comprehensive care. This holistic approach improves both mental health and HIV outcomes, enhancing clients' quality of life. In Vietnam, our integration of mental health services into HIV programs is guided by the HC model, as you can see on the screen. By following the HC model, we want to ensure a systematic and client approach, and that mental health needs are addressed based on evidence, culturally appropriate, closely monitored, and care not only for clients, but also for health providers. Next slide, please. We recognize the need for mental health support for EPIC program beneficiaries during the COVID-19 pandemic, and we integrated mental health into HIV services starting in 2022. Results of the baseline assessment showed that 80% of HIV services providers needed training on mental health, while 45% of clients reported needs for mental health counseling. Next, please. Based on this finding, we trained health staff at HIV treatment services on basic knowledge and mental health screening with a focus on key populations using standardized tools. Public and private sites then started conducting screening with routine checkups. Data are updated regularly on a Power BI dashboard, as you can see on the upper right-hand side. After piloting screening, we found that identification rate was lower than estimates for the general population in Vietnam, except at one clinic. This clinic applied self-administered screening, while others used counselor-led approach. So we conducted a sound-to-sound clinic learning exchange to introduce self-administered screening to other sites. One of the major gaps has been the referral between HIV and professional mental health services. Since this July, we have been working with public HIV treatment facilities, KP lab prep clinics, and specialized mental health facilities to improve the referral network. Next, please. As part of the work, we expanded engagement with the broader LGBTQI community. We are collaborating with a local social enterprise to promote mental health among LGBTQI community, including capacity strengthening, demand generation, and ensuring clients are referred to KP-friendly providers. We are also developing an online booking platform to increase the accessibility of clients to mental health services. Next, please. Besides, we are working with the Ministry of Health to standardize a national mental health training curriculum for health staff, which we first developed in 2022. The curriculum will be used to expand training broadly in Vietnam using our local national trainer. So this is the end of my part. Thank you for listening, and now passing it to my colleague. Over to you, Quy.
you, chị Thu. Next slide, please. Hi everyone, my name is Quý. I'm the project specialist working in the COVID Vietnam team from the EPIC Vietnam team. And in our team, we focus in the mental health for healthcare worker in Ho Chi Minh City. So we over this, we focus on 3 objectives. First is strengthen communication and raising awareness among healthcare workers. And secondly, to build capacity for mental service delivery to wellness navigators. And lastly is to improve leadership understanding and positive work control through activities such as wellness room, leadership trainings. Next slide, please. That is our final objective, which is to build capacity for mental health services delivery by training wellness navigators to lead communities of practice. So those wellness navigators are existing staff in the hospital throughout the province whose role is to enhance mental health services delivering by supporting providers in screening and access to services, cultivating a supportive network, collaborating with other navigators and monitoring activity. And this role also mobilized resources and effective mental health communication for the whole facility. To date, we have trained 160 healthcare workers from 67 health facilities among the province to serve as the focal wellness navigator. Next slide, please. The DOH, the Department of Health of Ho Chi Minh City, they also wanted to be sure that the provider and the wellness navigators knows where to get help. So we supported them to map the psychological and psychiatric services as well as primary care clinics, and including them on the integrated database with the Google Map application. So we could say that like we are the GPS for their mental health services and need finding and helping everyone to navigate their ways to a better support, including healthcare workers and general population. Now I would like to hand things to my colleagues, Prasanas from EPIC team in Nepal. Next slide, please. Thank you.
Okay, thanks, Quy. Let me just thank you, Vietnam team, for that. And so, as Jen said in the beginning, we're going to hold off questions until the end. And so now we're going to move to another EPIC project country, Nepal, where you will hear from Dr. Prasanna Katawada, who is a technical specialist and has focused on mental health programming related to people infected and affected by HIV. Prasanna, please. Thank you.
Hi, everyone. I am Dr. Prasanna Katawada, and I will be sharing EPIC Nepal's experience with integrating mental health services into HIV program in Nepal. Next slide, please. So we integrated mental health services into our HIV program back in 2022 after understanding the growing need of addressing mental health in the country, especially among people living with HIV and key population. Next slide, please. Since all our sites supported healthcare needs of PLHIV and key population, we were at the right position to integrate mental health services into the pre-existing HIV services that was from 37 districts of the country. Next slide. So some of our key interventions that helped in integrating mental health services initially were we utilized our community and clinic-based HIV testing and treatment services as the entry point for mental health screening. We developed SOPs to guide screening and referrals. We used a task-sharing approach to mental health screening where laypersons and non-mental health professionals were trained to screen for common mental health conditions and provide basic care as needed. We use specific screening tools validated for use in low and middle income countries to identify common mental health conditions. We trained our case managers and community workers using training modules, and an effective mental health service referral system was also built in connection with trained medical professionals in the country. Next slide. So this slide shows the 3 screening tools that Epic Nepal uses to screen for mental health screening. The first one here is the Kessler-6. Now, Kessler-6 is a 6-item screening scale to screen for the initial psychosocial distress. And anyone scoring 13 or above 13 are then referred to the facility to be screened further by PHQ-9 and Audit C. And the 2 other screening tools that you see in the screen, it's the PHQ-9 used for quick depression screening assessment. So this is done for anyone who scores 13 or above 13 in Kessler-6. And together with that, at the facility, our case managers also screen for the Audit C, which is a quick screening tool to detect harmful alcohol use. Next slide. So these screenings are conducted at the community and at the clinic, and specific referral system is used. Our community workers screen with KS at the community, and anyone who scores 13 or above are immediately referred to the clinic, where our case managers conduct further screening with PHQ-9 and Audit C. Upon further screening, if the need be, patients are then referred to the psychosocial counselors. We have psychosocial counselors at the sub-national level, and we have psychiatrists, MD psychiatrists at subnational levels as well. So if treatment is required, then the psychosocial counselors refer the patients to higher healthcare centers. And we also have a national level psychiatrist who guides all of these processes. Next slide, please. So when we first started the mental health screening integration, there were a lot of challenges. The data here shows how the mental health screening cascade looked like in the first 6 months. That is from August 2022 to February 2023. So only 30.7% who were reached by our HIV services received the initial mental health screening with K6. So the coverage was low, and also being diagnosed with psychosocial distress using K6 was low at 0.5%. So this data is just for the initial 6 months after integrating mental health into our services. Now, through 2023 and 2004, over the years, these numbers have changed. Next slide, please. So in this slide, you can see that we have 85% of the people reached being screened with the initial K6. So the coverage is increasing, it's increasing steadily, and identification of psychosocial distress using K6 has gone up to 0.9%. And furthermore, the linkage to higher care center is at 97% now. Next slide. So one thing that we noticed with Kessler-6 was that even though more people were getting screened at the community by our community workers, people getting diagnosed with psychosocial distress with community level Kessler-6 screening, this was still low. The K6 was diagnosing psychosocial distress more at the clinic rather than at the community. So you can see here that only 0.7% got detected with mental health condition in the community as compared to the 1.6% at the clinic. Now, even though 71% of these cases were screened in the community. So with this finding in FY25, Epic Nepal is replacing the community-based Kessler-6 screening tool with a community-based detection tool. Next slide, please. So, after we integrated mental health into our HIV services, we faced significant challenges. Some of the challenges that we faced were barriers such as language and culture. Since Nepal is a multi-ethnic country, the language and the cultural scenarios were changed district after district. So that was one of the barriers. We also faced limited number of mental health experts in the country, which affected our referral and linkage system. Next slide, please. So to overcome these challenges and increase our mental health coverage, we have worked on providing more training and orientations to our laypersons, community workers, and case managers. We have also increased our mental health human resources and strengthened referral network. We have also been able to coordinate with the government to develop a national SOP on mental health services for key population. And we have been conducting continuous assessment of our mental health integration system. so that we can detect challenges and best possible way forward, like integrating CIDT after we found out that community level Kessler-6 screening was not working that well. Next slide, please. So for us, the way forward for FY25 is that we plan on continuing these activities, and we plan on strengthening engagement with beneficiaries, coordinating with the government, strengthening referral networks, and also using online booking applications for mental health services to increase our coverage with mental health screening together with HIV services. Next slide. So my presentation ends here. Thank you, everyone.
Thank you so much, Prasanna. So again, you've now heard two examples from two countries in the region that have integrated mental health services into their HIV programming. And I think you can see that with both programs, there's been intensive use of data so that this data then can be used to provide feedback to both of these programs so that they can reassess the quality, make adjustments on the workforce and the quality of training so that there's better service quality in the future. So I think we've used up our time, so I'll pass it back to organizers. And then if there are any questions for both of our presenters, please let us know. Thank you.
Great, thank you so much, Steve. And also to Prabha, Roy, to Kui and Prasanna for those presentation. I have so many questions, but I'm going to turn the floor over to Ive to help us take the questions and comments from the participants. Ive?
Thank you very much, Jen. And thank you very much to all our speakers and resource persons. I actually like how all the different country level perspectives from India, Philippines, Vietnam, and Nepal actually complement each other and actually identify some shared areas of gaps, challenges, and also ways forward. So at this juncture, we're very much welcoming any questions or reflections from our participants. You may use the chat button or you may just raise your hand if you want to give your question live. So hopefully we can maximize this opportunity that we have different diverse perspectives coming from different organizations, be it around community resource mobilization, domestic resource mobilization to governments, and then even multilateral support. So any questions at this point? Maybe I can take the first stab first. I think this one's more for Prabha and Troy, acknowledging that your two organizations actually come from different nature. How do you see potential collaborations in the future wherein, for example, people working within TB have this appetite for mental health, and for the likes of Roy's organization, working in mental health first and then later on also collaborating with different HIV and TB? What do you think are the most immediate action points for different civil societies and community organizations to actually enjoin the government or even other actors to further accelerate the integration agenda? Because I can see a lot of similarities in terms of siloed system in India and the Philippines. Any of you first?
Yeah, basically, as I said, actually, I didn't have much time to show my last slide in terms of resources. Because there is in one hand, we say that definitely there is a shortage of funds. And even if the funds are allocated, it does not penetrate or it doesn't percolate for the program as such. So we need to have a second plan. We need to create a plan B for that. And so what we've done a mapping of resources. So what are the possible resources and how we can converge the needs and the available services that are available. Like, for example, there is no budget for conducting trainings or capacity building for mental health in mental health healthcare workers. But we have roped in all the experts from mental health institutions to conduct workshops, on a very small honorarium where it is not necessarily budgeted. So the end is met. The outcome of that training is that they have to be trained well to meet the needs of TB patients. So similarly, we have reached out to big mental health institutions where they have their interns. So they are also requiring an opportunity in an organization where the interns who are already trained, they get an opportunity to experience it. So we invite all those interns. It's a kind of a win-win situation for the mental health institution, medical institutions, and for us also. So there is a lot of give and take. That's how we have
Indeed.
leveraged.
Thank you very much, Roba, for sharing that one best practice example. Roy, over to you.
Yeah, and maybe to add, I think I touched a little bit earlier regarding that this public health issues are highly stigmatized. I think both for mental health advocacy, TB, and HIV advocacies, we could share best practices and how we were able to destigmatize these kinds of public health issues and learn from each other on how we can improve and educate. And specifically, I think for the mental health space, in the Philippines, there are very limited trained psychiatrists who are also adept or are also able to communicate properly HIV advocacies. There are very few psychiatrists who are properly trained on that one. I think we need to invest more so that more persons with lived experience will be able to receive mental health care and service that are appropriate for them.
Thank you very much indeed. Stephen, please go ahead if you'd like to share some rejoinders.
Just to add that the problem for many of these organizations that are doing this work is that it's funded by international donors. So on the HIV side, that would be through PEPFAR agencies like CDC, USAID, or the Global Fund that does HIV, TB, and malaria. It's very difficult to get domestic funding from host governments. Having said that, Thailand is an example that where the National Health Security Office here in Thailand has started to fund community-based organizations for their HIV testing and some PrEP support. They have now started to see that these organizations are also good at providing mental health services. So it would not surprise me that the advocacy and discussions that we're seeing between the community organizations we support and the Thai government will result in some mental health reimbursements to these community-based organizations. It's partially related to what Roy was talking about related to PhilHealth in the Philippines, which also provides reimbursements to community-based organizations for HIV prevention and treatment. I don't believe in the Philippines they're providing support. PhilHealth is providing support to community organizations for mental health, though that might be something for also these HIV organizations to advocate for in the future. So I just wanted to make that point of there are some small rays of light for domestic funding support for mental health services targeting key populations.
Thank you so much, Stephen. And actually, that was one of the potential questions from the audience about sustainability and integration. While we're actually at the topic, and thank you so much to our colleagues from FHI 360 for showing some best case examples from both Vietnam and Nepal, where there are areas where you actually demonstrate impact, and especially with different interventions that you start at the scale. What are the potential challenges that you see when you start scaling this up to a larger level of coverage and population? So I guess some of the highlights earlier is around cultural barriers, the lack of service coverage, and also the inadequacy of mental health workforce. What else? What other challenges do we foresee that other communities can also potentially relate to when we start scaling up these kinds of interventions?
Okay, should I go first or?
Yes, Prasanna, please go ahead.
Yeah, I think one of the challenges would also be funding and the realization that mental health is as important as physical health as well. So the whole healthcare system needs to first realize that this is actually real. because like especially in South Asia, mental health is considered something of an invisible situation that affects a lot of people, but no one kind of sees it in front. So I think that would be one of the biggest challenge for sustainability, for people to understand that mental health is actually a really big problem.
Thank you, Prasanna. I think to her point, really emphasizing the need to appreciate the parity between the physical and the mental health aspect. And I think one example of which also is the high-level meeting on TB, where I think for the first time there has been an inclusion of the language around mental health being equally important on the physical health aspect. Harry, please go ahead.
Okay. Hi, Prasanna. I have a follow-up question, basically from what you just mentioned. As you say, the challenge in the South Asia, like talking about mental health sometimes, is something not really feasible, when people like admit it, they have a mental health issue. So, and you do some screening from 2023 to 2024 with the highest numbers up intake from that screening. So all those screening process, do you do it just coming to the community, or the community come to you, or how it works? How the screenings being conducted?
Yeah, so the first level of screening, which we use the Kessler-6, the 6 questions that we screen our patient with, we do it in 2 ways. Our community workers go out in the community and then they screen clients who are usually seeking HIV services like prevention, testing, or treatment services. So when our community workers go out in the community to provide these services, they screen for the mental health, like a rapid screening. And then there's also another way where where our patients, when individuals seek out HIV healthcare services in the clinic, then our case managers screen for like psychosocial disorders with the Kessler-6 in the facility based as well. So as you see, like I had highlighted part in the presentation where we saw that community level mental health screening was actually detecting very low level of psychosocial distress compared to the clinic level, even though their coverage was high. So I think that part shows like how people, when they come to the clinic, when it's a clinic setting, people are more probably willing to, or like have self-awareness of talking about mental health, rather than them being in the community and just like talking to some community workers about their psychosocial distress. So that part was highlighted in our data.
Lovely. Thank you so much, Prasanna and Harry, for that question. Any other last question? Since we're almost actually close to the time to end. There be none. Jen, do you have any further questions or not? We can hand it over back to you for some quick thought.
Thank you, Ivan, and thanks to all the presenters and the questions from the audience. I think we could spend a long time to talk about it, but I hope this is certainly won't be the last time for us to be talking about this. Before we close for the day, I actually have a couple things that I would like for us to go through. We have 10 more minutes left. Can we, and we have to do this because it's customary thing, can we get a group photo first? If that's okay with everybody, if people are okay to turn on their videos. Because the regional coordinator for GFAN, she has kindly requested and sends her apologies. She's in London at the time, trying to get more resource for us to do work here in the region. But Ken, can I have it over to you to instruct us for the group photo?
Yes, of course. Thank you, Jen. So anyone else who wants to turn on the cameras, now is the chance to show us your beautiful face. We will be taking a photo and I will give us a countdown. So please smile. 3, 2, 1. We'll do one more. 3, 2, 1. Lovely. Thank you so much. Over back to you, Jen.
Great, thank you, Ken. And please don't go, everyone. Before we close today, I want to invite Ken to share a little bit of information about GFAN AP's upcoming campaign for the ninth replenishment of the Global Fund. And I know that we just spent the last hour talking about resourcing issue and various opportunities, including domestic resource financing as a mechanism on how we can advocate and scale up and make quality integrated mental health services available. Some of you might be aware that an aim of GFAN AP is to facilitate consolidated advocacy effort by communities and civil society in our region towards sufficient investment in health, especially for HIV, TB, and malaria, and through mobilization of resource for the Global Fund, as well as increased domestic financing for the 3 diseases. So within this context, we see Global Fund as an important funding mechanism for our region, just as much as we see PEPFAR and some of the other technical agencies, their contribution to this really important issue. So Ken will, so we'll continue to work on advocating for programs and services that we need to the Global Fund and to the different donors and to the country governments, including mental health services for impact for health outcome. And in the context of the Global Fund is through the Global Fund's investment in our region. So I'm going to turn it over to Ken for just a couple minutes to share the upcoming campaign concept that GFAN AP will be releasing after the new year, a kind of a sneak preview, and hoping everybody will continue to work together with us on how to maximize, funding such as the Global Fund to our region, especially for vulnerable and key populations. Ken, over to you.
Thank you very much, Jen. Hi, everyone. My name is Ken. I'm with GFAN AP as the Communications Officer. And as Jen had mentioned, we are working hard to scale up our efforts in preparation for the 8th replenishment of the Global Fund, which will be taking place next year. And we have had a bunch of conversations, meetings, discussions to get input from communities and civil society on the concept and messaging that we want to highlight leading up to the 8th replenishment. This will be the Asia Pacific response, and this is a chance for us to talk about issues that matter to our region in the Asia Pacific. So it is my pleasure to share with you the outputs of these discussions so far, as well as a content working group, a communications working group with Asia Pacific civil society. I am sharing my screen. You should be able to see on the screen the campaign hashtag. I'm very excited to share that the hashtag for the 8th replenishment campaign will be from GFAN AP, and the Asia Pacific will be hashtag more now than ever. This is a hashtag that encapsulates messaging around urgency, around importance, highlighting that this is the replenishment that counts if we are to achieve our goals towards against the 3 diseases to looking forward towards 2030. We are also going to be putting out messaging around the 4 core thematic areas through this campaign. The 4 areas also have their respective hashtags, which are secondary hashtags. The first one will be hashtag let communities lead. Here the call is very much around pushing for more equal power sharing, more equal voices at the table, shifting of power, and for communities to be at the forefront of conversations and decisions at all levels. The second area that we will be messaging strongly on is connecting the gaps, or hashtag connect the gaps. Here we're talking not just about funding gaps, but we're also talking about access gaps and engagement gaps. So we want to include all key populations and vulnerable groups in our advocacy, and we also want to ensure that this access is provided to all and is of high quality. The third thematic area that we'll be focusing on is on accountability through hashtag accountability for all. We will be communicating that basically all stakeholders have a role to play And it is not just about the usage of funds, but also about, again, going back to making sure access to health is equitable. And that requires also differentiated approaches and strategies in the way that we carry out our programs, especially in different country contexts. And the fourth thematic area is on protecting our rights, our lives. So this is reminding our governments that it is their responsibility to protect our rights as citizens and as communities. But at the same time, it is not for them to control our lives, as we all have our fundamental human rights. And we will also be addressing this concerning issue of shrinking civic spaces that we have been observing in recent times. So this is an overview of our hashtags that we will be using, as well as the key messages that we will be communicating through these hashtags. I have just one more slide. For our seventh replenishment, which I also had the pleasure of working on, you may remember that GFAN AP had a campaign around paper cranes and paper elephants. So for the eighth replenishment, we are going back to the idea of community craft. We want to communicate through the craft something that is accessible to all, as while having meaning of hope, of fortune, of support, and of love. So we want to keep a positive feel to this, but at the same time, we also want to communicate that we have expectations and we have wishes as communities. So the vessel to communicate this, which we have collectively agreed on, is paper stars, which can be folded from a single strip of paper and can be presented in multiple ways. It can also contain messaging written inside the strips, so it can be representative of messages that we wish to bring to the table from community members who may not have the opportunity to be there in person. And we are currently designing various ways that we can make use of these hashtags, concept, as well as visuals in our 2025 campaign. So there is a lot more to come, and we will definitely be in touch again in the coming months to share with you the activities that we have lined up. Thank you very much. Pass it back to you, Jen.
Great, thank you so much, Ken. And just to also know that during our consultation process, integrated mental health services was also one of the key topic that came up that people really want to make sure that we incorporate into our campaigns for the eighth replenishment as a key area of work that needs to be resourced and funded by the Global Fund. So this is all very much in line with everything we're talking about. So thank you so much again to all the speakers and participants for joining our session today. This is the last of our webinar series on integrated mental health services, but I hope it won't be the last time that we have this conversation. And I hope that through our collective voices, we can start putting integrated mental health services on all national health programs agenda, especially health services for key and vulnerable populations. And I'd like to give the final words to Ive to help us close out the session today. So Ive, over to you. And Ive and United for Global Mental Health has been an invaluable partners for us in developing the series. So thank you so much again, Ive. Over to you.
Thank you so much, Jen. I think wouldn't make it long, but more work ahead for all of us, but also collaboration is really the key to bringing us closer to our integration agenda. And there are lots of opportunities next year. Aside from the 8th Global Fund replenishment, there's also the high-level meeting on NCDs and hopefully mental health, which is very much relevant as well for our communities, and also the high-level meeting on HIV in 2026. So hopefully we can still really collaborate on so many things for next year. We're also going to do a lot of dissemination webinars regarding some research that we're working in. For example, how mental health has been included in the different Global Fund national grants, which covers all different countries. So if you have that interest to know about the landscape of your country, hopefully we can touch that in the webinar in Q1 of next year. But for now, thank you very much, everyone. I hope you take the time to slow down, break from work, and also protect your own mental health every now and then as the year ends and a new year unfolds. So thank you, Jen. Thank you to GFAN Asia Pacific and Seven Alliance for this wonderful partnership in 2024 and more to come in 2025.
Great. Thank you so much, everyone. Enjoy the rest of your day and see you after the new year, everyone. Thank you. Bye-bye.
Bye.